Health Innovators, this is our 43rd event we are hosting. I'm so glad that you're able to join us. Thank you. We've been around for more than 2.5 years, and we have hosted 40. This is our 43rd event, and so far we have 4,826 members in our community. Healthcare in America is broken. The current healthcare was actually built in 1965. That's when CMS was born. But at that time, there were a lot of, if you look at the demographics, there were a lot of young people. But now, if you look at the demographics, there's a lot of baby boomers who are retiring. And this calls for a new change in the system, because we have gone from acute illnesses to now chronic diseases. Chronic diseases require a lot of care coordination. If you look at it, one of the problems care coordination causes is readmissions, medication reconciliation problems, patient not being engaged. Imagine a patient with diabetes. That patient has a big care team. For example, they have a primary care, endocrinologist, nephrologist, neurologist, podiatrist. So the primary care has to coordinate the care with all these team members, and it's a difficult task. That's why we get problems like readmissions and medications. Well, I don't know much about care coordination, but we have a lot of experts today who are going to talk about care coordination. Let me first invite our first speaker, Michael Doyle. Michael Doyle is the former CEO of MedSphere Systems Corporation. He was a developer of OpenVista. He was a former president and CEO of Advantage Health Solutions, former founder and CEO of Standish Care, former senior leader of VHA, senior medical leader of National Medical Enterprise, former strategist and operation expert at North, featured in national publications and television programs, and he's also a fellow in the American College of Healthcare Executives. Michael Doyle is currently the CEO of Cupid Health. Please join me in welcoming Michael Doyle.
By the way, I have no idea who he just described. Let me start by just telling a story. So I'm CEO of this really innovative, great company called Cupid Health. And it's got a cute name, and people remember the name. It was born at Partners Healthcare about 10 years ago. It was born because a radiologist was sitting there looking at scanned data in a dark room, and being a good radiologist was trying to find contextual meaning about what he was looking at in the scan. So being as diligent as he was, he's going back into the record, the medical record, and trying to find what is really going on with this patient. And of course, 80% of the record is unstructured data, it's text, right? So he's like, this is kind of ridiculous if you think about it, right? This is a scheduled procedure. The information has been available about this patient for quite some time. Why couldn't we marry sort of concurrent information about the patient in summary format and make it available prospectively for physicians and nurses to enable them to make a complete diagnosis, and a better diagnosis, a more accurate diagnosis about the patient? So he began working on this problem about 10 years ago with a computer scientist, and they started solving the problem. And they're very smart people. They're interventional radiologists, they're physics majors, they're brilliant and great clinicians. And this became so vital and viral within the Department of Radiology at Mass General. It quickly went to the emergency room. The emergency room doctor said, we'd like our own portal. And then it went to gastroenterologists because they had a problem in that they were performing colonoscopies. And people know what the god-awful bowel prep is like, right? And the last thing in the world you want to do is go through that and then show up with your gastroenterologist, and they asked us 7 questions about risk factors, and they say, oh, we didn't know you have a history of COPD and you have sleep apnea, and by the way, you're on blood thinners, we can't do your procedure. So that was a major, terrible problem. So Cupid then began going into the record a month before, scouring the record, looking at risk factors, and notifying the gastroenterologist that this was a problem. And so today at Mass General, you do not get your procedure canceled because you have a pre-existing condition, because Cupid already knows that and informs the gastroenterologist about that. So anyway, it went viral throughout Mass General and then across the chasm, and it went to the Brigham. Now, I don't know, I think there's people from the Brigham here, there's people from Mass General. That's a bit like the Hatfield and McCoys. The fact that people in the Brigham, physicians at the Brigham and nurses at the Brigham would use this application was developed at the General is truly astounding. So today we have about 7,500 doctors in the Boston area using this in about 10 hospitals. We've deployed it via the cloud to other institutions across the country. We've got a major partnership with Epic, McKesson, and others. And I'm going to tell you why this is so important in today's healthcare. And I agree with the speaker that was up here earlier. We're vastly migrating and quickly migrating to unfortunately, my generation, which is the baby boomers, who are aging quickly, who have one or more, 2, 3, or 5 comorbidities. We're very complex patients. 80% of our records unstructured. That record is increasing by about 8, individual records are increasing by about 80 megabytes a year, and most of it's text. And it's a lot of it's noise, but there's really important clinical nuggets in the record. So our job at Cupid is getting that information available and making it available prospectively to those doctors and nurses and allowing them to make a better clinical decision. So with that, let's see my presentation. Okay. So far we've spent about $70 billion on EHRs, $21 billion from Medicare, $9 billion from Medicaid. Great, we have electronic information, now what are we going to do with it? The problem was EHRs were going to fix all of our operational issues, as well as interoperability issues, as well as primary care issues, and it turns out they're essential, no question about it. But unless you make the data actionable, it's just not enough. And if we're really going to find those hidden clinical gems, we need applications and tools that can sit on top of the HIE, that can sit on top of the EHR, that can sit on top of the clinical data warehouse and assist primary caregivers in providing the best care that they can provide to the patient. So sharing is hard to do. In today's medical environment, where we have access to all that data, we have very little, as we know, interoperability, right? We have data, but we can't do much with it. It's kind of like the Roach Motel, data goes in but doesn't come out, right? So this has to change, and we're at the forefront of change. And I will tell you, there are many fine companies represented in this room. The people, the entrepreneurs in this room that get behind this movement of actually taking data and making it actionable will be winners. There's going to be hundreds and hundreds and hundreds of companies started to try to do something with all this data because it's really important. So the problem is, because there's so many challenges and problems in the medical record, there's lots of errors that happen. The narrative a lot of times is mismatched. There's a large administrative burden now with reporting. So we have the data. It's interesting, it's important. How do we take that data and actually populate registries? How do we do PQRS reporting? How do we do all the governmental mandated things that we have to do? I would argue that the only way, traditionally in healthcare, what we've done is we've thrown bodies at it. We said, okay, let's hire 10 more FTEs, or let's do this, or let's do that. And that's not going to work going forward, because hospital margins are being eroded. And the old approach to throwing bodies at a problem is just not going to work. We're going to bankrupt ourselves very, very quickly. So again, I would argue there's a lot of opportunity for companies to help solve this particular pain point. We often say that finding the appropriate data in a medical record is often like trying to find a needle in a haystack, and it's really hard to do. So think of us as Google plus Cliff Notes divided by the EHR. That's really what we are. And these, I think we have some pins available for people and some stickers if you'd like to see that. So what we do is we use natural language processing on top of the record. And NLP by itself will be a commodity over time. So what makes Cupid different is we have NLP, but we also have the largest clinical data repository of query language built in the United States. Now, how do we have that? Well, we've been doing this 10 years, and I'll show you some numbers in a moment about the number of transactions we do every year. But we've had arguably the best and brightest working with us for 10 years, residents, fellows, attendings, nurses, nurse practitioners, helping us refine our query language. And then we use machine learning on the back end. So just like Google, which gets better based on popularity, we get better based on finding affirmative data that supports a particular patient's case. We can filter things by clinical concepts. We can also do billing codes and filters, but we go way beyond that. And then we display it in a way that's meaningful for a physician or nurse. Physicians and nurses think about body systems. They don't think about the way that most EHRs were architected, which were really revenue cycle applications that morphed into the clinical space. We started in the clinical trench. We understand how physicians and nurses think, and that's how we've architected the system, and that's why it's so popular. We have a bunch of portals we've built that are meaningful to our clinicians. We found this doesn't necessarily sell our application just because we make doctors and nurses happy, because CIOs and CFOs, CFOs and CIOs want to know how are we going to improve patient care, how are we going to improve patient safety, how are we going to coordinate care, how are we going to get people from being readmitted to the hospital, how are we going to do our reporting for PQRS or registries. And to put the problem in perspective, we just signed Providence Health System on the West Coast. They have 34 hospitals. They have to maintain 121 different registries. They've been doing that manually for the last X number of years, right? They can't continue to do that, right? It takes them a half an hour, hour and a half to manually extract information from the record and manually populate these registry forms. And they have 34 hospitals and 121 registries on average they have to maintain in these hospitals. It's going to break them. Yes, sir?
Do you have the percentage of error that goes in terms of that measurement? Obviously, there's a tremendous amount of error.
There is a tremendous amount of error, and I don't know the exact number. Does anybody from Cupid know what that number is? I know it's high.
Yeah.
Manual extraction, I know is high, and we're much more accurate doing it with the system. That's a very good point. The other thing that we do, which is, I think, way ahead of the market, so I don't want to spend a lot of time on this, but it's the future of medicine, in my opinion. We have this thing called, in the clinical world, within partners, it's called ProE. What we call it in our world, the commercial world, is called QGuide. And what this does is, we've partnered with the American College of Cardiology, we've partnered with the American College of Surgeons, and we've taken the best practice guidelines for treating particular maladies, right? So this is an example of carotid artery disease. If you've got carotid artery disease, there's three things that people are going to do for you, generally. They're going to open up your carotids, dissect them, and scrape you out. They're going to put a stent in, which is abbreviated CAS, or you're going to be in medical therapy the rest of your life. Now, there are risk factors associated with each of those procedures. Cupid goes into the record, understands your relative health status, right? Because we can read the entire record. We've been doing it for many, many years. So we know that the risk factors associated with an 85-year-old woman with a history of COPD and type 2 diabetes is very different than a 35-year-old man with no pre-existing conditions. And based on your condition, based on accepted guidelines, we marry the two of those. And we present to the physician a green, yellow, or red light. The physician they can choose whatever they want to do, but if they go into the yellow area or the red area, then they got to document why they did that. So this has got the attention of insurance companies. So we have a pilot with Blue Cross and Blue Shield in Massachusetts, where if you're a spine surgeon at the General or the Brigham, you don't have to call Blue Cross and Blue Shield to get authorization or prior authorization to do a spine procedure. Because the outcome data is so improved from using this application, and the risk factors are greatly diminished, and partners' stated objective is to provide 100% appropriate care for their patients, the capitated population as well as the insured population. So how do you do it? The only way you would do it, I would argue, is to use tools like this with medical judgment. So you're ensuring that you're providing the most appropriate care for the patient. And then you can do benchmarking studies, you can do outcome studies, and if you find a rogue doc that keeps going into the yellow zone and the red zone, and by the way, the outcomes aren't good, then you can have a teaching moment with them. So because we are developed by clinicians, we think like clinicians, they think in concepts, right? And that's how we've developed the application. We help them and assist them in clinical reasoning. That's really what we do. And we understand things like an EF fraction, right, for heart output. We understand what that is. We know what a normal EF fraction is. We know what an abnormal EF fraction is. EF fraction is not in a defined field anywhere. It is not a structured data element. It's in a narrative somewhere. We can go find it and understand that about the patient, right? So we improve clinical care tremendously. It lets the story or the narrative live. If you actually go talk to CMOs and CMIOs, the number one complaint they will tell you is that EHRs are forcing us to do checkboxes. We don't do checkboxes. We don't like checkboxes. We didn't learn to practice medicine with checkboxes. Now, why are they saying do checkboxes? Because that's the only way structured data can get out of an EHR. We eliminate that problem. Dictate away, doc. Have a blast. It's fabulous. We let the narrative of the patient live, which is how physicians understand patients, right? We bring that story alive. And that's why I think we have so many physicians that really like what we're doing. So we've just been voted by Gartner as one of the cool companies. I don't really understand what that means. They certainly didn't have my picture when they gave us that award. But we're doing something really innovative, very interesting, and very, according to Gartner, very cool. So why we're so excited about being here and being in Boston and owning this enterprise and continuing to make this better and better and better is this slide, where we actually, all viral adoption, 10 hospitals, 7,500 physicians. We did 550,000 patients last year, and we had 3.5 million clinical encounters. And we're replicating this now across the country. We're looking for talented people that want to join us on this journey of improving quality of care for patients and their families. And that's it for me. Thank you very much.
Is this used as a clinical decision support?
Yeah, it's a variation of it. I mean, we do a lot of more things than just straight up clinical decision support. We actually call it applied clinical reasoning, which is a little more kind of the way we think about what we do. It's really, when you try to put us in a box, it's hard to do that, which is good and bad. We view it as a greenfield opportunity that's going to expand, and we're one of the leaders in the space. There's other companies that are trying to do what we do. You know, Watson, you could say, is trying to do something what we're doing. They're doing it completely differently the way we are. There's a few other companies. Yes, sir.
How do you evolve the rule set and make sure that as you're evolving it, that you're maintaining the efficacy and sort of getting better all the time?
Okay, so the rule set we actually rely on professional organizations to give us the rule set. So we don't define the rule set. We use generally accepted practices from the American College of Surgery, the American College of Cardiology, whatever they are. And as those rule sets change, which they do, we actually have built this in a very modular fashion, which allows us to put that best practice into the application and allow them to operate that way. So, yeah.
Since he asked my question, I'll ask another one.
Uh-oh.
I noticed that you had the procedure and the consent for the procedure.
Yep.
Do you take it further along with some shared decision making, or is there a tool
Great
that
question.
goes with that?
Okay, so what we do, the way they do this, the way the workflow works at the Brigham and the General, is those risk factors that I had up before are shown, and then the physician will sit down with the patient, and they'll show them the risk factors associated with this particular procedure for them. And then they'll show them the national risk factors, which we print out on a consent form. So the patient, the family has national risk factors, and then they have their own individual risk factors, and the physician then will have a dialogue with the patient about their particular risk. And they'll jointly make a decision about how to treat it. And then that automatically, once they make that decision, consent form is signed, it goes into the scheduling system, and the procedure gets scheduled. And they avoid prior authorization with the insurance companies. Now, why this is important is we eliminate this tremendous friction in the market, right? So To put this in perspective, Partners has 300 people that do nothing but call insurance companies to get prior authorization for their doctors to do procedures. Blue Cross and Blue Shield, I've been told, has about 1,000 people that answer the phone and say yes, no, maybe so. We just it's all objective information for us. We just eliminate the middleman out of the equation, and we believe that we're providing more appropriate care through technology and judgment. Yes, ma'am.
Yeah, I'm trying to get someone to include within health records, dental records, because it's a huge driver of health or disease. The other thing I'm interested in, and maybe something you could move into, is going upstream, like why this person has heart disease, and therefore how to not just medicate it, but how to improve the environment in the body so it doesn't keep reproducing itself.
Okay, I can't comment on the dental records, but I can comment on your second point, which is, what do you do and how can you do research and how you can find patients and how you actually start thinking about that. So one of the applications I didn't show you is an application we developed called Q-Scout. And Q-Scout is, think of it as it used to be called cohort mater or something, but it allows you to actually slice and dice maladies or demographics or segments of patients across records. So you can use it for clinical decision support, clinical finding cohorts of patients. Like you could find, okay, give me African Americans between 25 and 65 who have type 2 diabetes, have COPD, have a history of heart, some other heart ailment. And you actually can find those patients for clinical research purposes or whatever you want to do. Yes, sir.
I see that you're working with Partners, Brigham, and Newton Wellesley, who are all Epic users. So how does this work with a non-Epic?
Yeah, so first of all, Partners is recently going to Epic. So Janine, how many different databases? Janine runs our clinical services, but how many different databases do we have
over
Partners?
10 or more different databases that are combined, and Cubit sits on top of them all. We're adding Epic now through the web services there because they're just going live on their clinical data. At Brigham, they just went live, but the rest, at Mass General isn't yet on the clinicals. So we can sit on more than one database. We can take data from different databases. As in terms of the dental records, if they can send them, we can take them. And if they send them in a textual PDF type of format, we can change that into text that we can read as well. So that's how it could be integrated. It just has to get into a central repository or an HIE or what have you, and then we can read all of that data together.
Yeah, we're completely agnostic about EHRs. We're on Vista, we're on Epic, we're on Meditech. I don't know how many different databases we're on at Mass General, but we're agnostic to what the data feed. Or it could be an HIE as well. This gentleman has an HIE. Yeah.
So you have interoperable solutions built in?
Well, we've created interfaces between the EHR in allowing us to extract information. We can also actually put the information back in if the EHR vendor will allow us to do that. Now, we've also figured out, if we have permission to do this, how to go across EHRs as well. But that's harder to do, but we've figured out how to do that.
So you basically convert the data, you pull the data in from a standardized format.
No, we don't. Well, it depends on Janine can talk about this a lot more intelligently than I can.
So it's much easier than creating like a clinical data warehouse. There's no mapping to a central box that you have to put everything in and normalize the data.
Okay.
We actually just take it all in, we tag it on the way in, and so then we can use it for any concept query that we have or anything that you can think of. So it's much easier and faster implementation.
Yes, sir.
How do you deal with contradictory data?
Yeah. So, Diane, do you want to speak about that, or what we do? I mean, I can speak about it, but you might be able to speak. I mean, here's what we do is, when there's an indication, the doctor can hover. If we go find, and we can do negation as well, in affirmation. So if we find evidence, or whatever he or she is thinking about, we surface that. Then the physician or nurse can see that, and then they can go into the record and actually look at where it came from in the record and do additional research. That's how we actually present it.
And then additionally, there's this concept of is it positive or negative? So, there may be no evidence of, and the physician may even say that, no evidence of X, Y, Z. and it will definitely tell you that, so you can tell whether there is or there isn't. So you can get those nuances.
Time for probably one more question, if there's any. Yes, sir.
So is your application an offline tool, or is it real time getting data from the EHR and processing data? I mean, EHRs are already bogged down with a lot of traffic, right? How do you able to see those data?
Do you want to explain that, Janine?
Sure, on some systems, they have a shadow database, so we'll take the data from that. It depends on the use case. For things like quality measures, we can have a latency of, getting the data every 24 hours, and that's fine. For something like a portal, we'll do HL7, so we'll just clone whatever HL7 interface they want to give us. We pull that data in real time, and then we'll take the extract either every 24 hours, or for some use cases, like notes will be every 4 hours, or medication administrations will be every 2 hours, so that we keep the records up to date as we can. But it's just slightly under real-time data. I mean, the EHR is still for the clinicians, it's still the source of truth. We just try to sort out what we can about that patient, and a lot of it has to do with their past medical history, is what they're looking for.
Well, thank you. Thanks very much.
Thank you so much, Michael. Our next speaker is Piali Day. Piali Day is the co-founder and CEO of Sensico Systems. She was also a former engineer fellow at Raytheon Integrated Defense Systems, inventor of Confluence knowledge-based decision support in military and public safety missions, accomplished many researches, including decision support systems, mission performance predictions, analysis and optimization, intelligence systems, automatic target recognition, including real-time implementation, sensor fusion, and physics-based simulation of infrared emission and photon transport. She was a former senior scientist at Spectral Science, Inc., and she's a Boston College alumna. Please join me in welcoming Piali Day.
Good evening, everyone. It's a beautiful evening, and it's just lovely to see you all. I think the best way for me to start my conversation is to say we're doing what Cupid and Michael Doyle's company is doing with EHR data. We're doing it in the home with data about chronic conditions in the home. And the answer, you're absolutely right, the answer lies in an interpretation of all the data that is informing of anybody's health situation, and that happens to come from all settings. There is the data that's in the electronic health record systems that's coming from the clinical setting. There is the claims data. There's a lot of insight that can be derived from that. But there also is a hugely untapped source of data, which is about behaviors in the home. And what I'm going to talk about is care coordination for management of complex chronic conditions, multiple comorbidities, and what's happening with patients with multiple comorbidities living day in and day out is what's happening in the home. And so that's the focus of our conversation. And with that, I'll also caveat, and I'll agree with Michael, that there is so much data that's available that is not subject to human interpretation. There aren't enough people in the world to look at all the data that perhaps comes from my grandmother every single day. It's got to be systems that automatically interpreting it. So my talk is about automated sense making for coordination of complex care with the data that can be harvested from the home. So the complex health challenges, what we just as a society have to wrap our heads around. More of us are just entering that retirement, 65, 70, 80s age, and most of us will live with multiple chronic conditions, and most of us will unfortunately live with multiple chronic conditions for a couple of decades, maybe even 3 decades. And if those conditions are not properly managed, we all know that it leads to higher incidences of hospitalization, more use of emergency rooms, cost is much, much more for folks with multiple comorbidities, and the essential healthcare challenge that we face as a society, and it's a global challenge, it's not just America's challenge, is knowing how to manage people with complex care, day in and day out. And we are an incredible system here in the US about acute care. When people go into the hospital, we know exactly what to do to patch them up, send them home, but then we forget about them when they're in the home. But we can't do that. So we've got to now cross that bridge from patching up to in the hospital to having total situational awareness within the home and to reach into the home and intervene in a timely fashion. And that's the solution that we are after. So the challenge for complex chronic care is absolutely amazing. Cal mentioned that somebody with diabetes, well, people may start with diabetes, but very often they end up with a heart disease and then a lung disease, and they have a myriad set of specialists. They've got their primary care physician, and on the other side, their support system is their family, their community. That's where they're dwelling, that's where they're spending their time. And this bridge between the support system that is there for you 24/7 and the specialist system that is there to patch you up when something starts to go wrong, that is the gap, that's the care gap that we have to fill. And our solution is intended for the folks who are filling that care gap. Out on the clinician side, we've got the electronic health record systems. Out at home, maybe we've got logs. Okay, maybe we've got daily phone calls with mom. But there is nothing that transcends the two. But the tools that we are bringing to the market connects the two through technology. And the people who are using it are extension of the care team that we are evolving into. And they are two very, very critical people that we have discovered through experimentations in bridging this gap with our multiple customers. And that is a patient advocate who's going to reach out into the home about all issues behavioral. How come you're not eating enough? How come you're not walking around enough? Why didn't you fill that prescription? It looks like you're not taking your meds, and that's having an impact on your blood pressure. What's going on there? So there's all of that social conversations to be had, and then of course if the blood pressure spikes or glucose drops, there is the clinical piece that also needs to be managed, and that is handled by the care coordinator. So putting in that safety net between what is acute care that we have perfected in this notion and the home care which we have failed to attend to is where our solution lies. So the promise of coordinated care that we are pursuing is threefold. One is we've got to empower patients and families to take the right action every single day. And oftentimes when they don't, it's because it's too complicated for them and they don't know what to do. So our tools completely begins with empowering the patients and the family members. But it can't stop there, because if something bad starts to happen in the home, someone has to intervene. And that is a complex care portal that we have developed that even not your primary care physician, but a tier 2 clinical system is going to attend to. But ultimately the goal is, as Michael said about Cupid, is understanding what's your population like. So if I'm an ACO responsible for 100,000 patients, I want to understand how many of my diabetics are not taking their metformin, is getting into regular episodes of glycemic complications. Understanding that your population at that level of granularity, which is the events that are happening in the home every single day, is where we think the power of transformation lies. And that's the analytics that we focused on. So our system is IBIS. There is a demo system back there that perhaps you'll get a chance to look at. But essentially, the system consists of a care station, which is a nice 17-inch touchscreen device. We have 94-year-olds using it. And just big buttons which tells them what they need to do on a regular basis 2 o'clock every morning, we lay out their daily care plan, and that includes all the meds they need to take, sequenced into when they need to take it relative to their meals, when they should exercise, if they have doctor's appointment. So here's your calendar laid out for you as it pertains to your chronic care for that day. So that's one level of activation, but then we're also analyzing everything you're doing in real time. So if your blood pressure spikes, we now start to activate you through a protocol for addressing episodic hypertension, while we send a notification out to your clinical team saying you are having this difficulty, be aware. The second component of our system is actually a passive set of devices for monitoring activities of daily living. We think that if you could just watch a person's movement, especially an elderly person's movement, it is very telling of how they're feeling. So we've got this passive activity monitoring system that's going to tell us if with the quality of sleep, the duration of sleep, was time spent in the kitchen cooking, the normal amount of time was time spent eating. Of course, it'll tell us about falls. Were there too many trips to the bathroom? Was the person even just too slow to get out of their chair that day? And is this a pattern that's repeating itself? Well, they could be cognitive issues, they are mobility issues, but they're caused by something. And it's that cause that we are applying artificial intelligence to discover. Are you less balanced on your feet today because you forgot some meds, or you double dosed on some meds, or you have a new med? What's going on in your home with respect to your clinical care that is impacting your health and mobility? We are integrated with devices that automatically collect physiologic and environmental data, but the essence of it all is artificial intelligence. We spent the first 2 years of our company's lifetime developing a very robust AI framework, which actually has its roots in, I came from the defense industry, a lot of intelligence data that need to be contextualized. So similar paradigm that we are applying here to understand how behavior impacts health. That's the essence of our view. And then we communicate all the insights through a care portal. And at the heart of all of this is automated interpretation of data. So the system constantly collects data, it interprets in real time, and in real time it notifies people, and in on-demand it creates reports. The on-demand function really is when a person has been scheduled to go see the primary care physician, hit a button, what has happened with this patient on a day-to-day basis since I saw him or her the last time. And that's what we are doing. Examples of sources of data, you're all familiar with it. Movement sensors, wearables, cameras, interactive devices, light sensors, biometric devices. And this is a good thing. We're going to just collect more, we're going to find more ways to pick up subtle cues about a person's situation in the home, but then we're providing the brain in the box to interpret it all towards answering some specific questions. And the type of questions that we are specifically answering is the patient taking his or her medications? Is he getting the right kind and the right level of exercise at the right time? Are they taking their meds at the right time? Sleeping well, depressed, blood pressure under control, medication having its desired effect. This was a medication to control the blood pressure. Is the blood pressure controlled? What are the risks of a hospital admission if we do not intervene at this moment? That's always a choice, when to intervene. Intervene tonight, intervene tomorrow, what does that look like? So those are the questions we are answering. And as I mentioned, we begin with a deep patient engagement system, touchscreen device, really easy to use. We are telling people what medications they need to take, when they should take it, etc. And then we're guiding people through clinical protocols, which are given to us by our customers. Our clinicians provide this system as a tool to their patients to help them manage their complex care. And this is the activity of daily living. We can look at it on an hourly basis, but more importantly, we can look at it as a trend basis and notice that someone's level of activity is slowing down over perhaps months. And those are all cues on what's going on. And why is it happening is what we are attempting to discover with the AI on the background. And at the end of the day, we are our care portal obviously displays a variety of data, but we are sending contextualized notifications that tell you what the situation is and what is our hypothesis as to the reason we are in that situation, missed meds, etc., etc., and allowing that early intervention. And we don't stop at that. Our goal really is to do this at the population level. So we are clustering in real time the patients by their behavior. So here's, for example, a diabetic population, perhaps with other comorbidities, whose medication and dietary adherence has certain impact on their hypoglycemic events. And so what does your clustering look like now, and how does it change in real time? You can watch a movie and see, oh my gosh, I've got this population shifting into this population. If it's a good thing, give yourself a high five. If it's a bad thing, do something about it, like do some training, do some coaching. Examples of population insights from IBIS. What portion of my population has poor diuretic adherence leading to fluid retention? Okay. A poor diabetic medication adherence leading to hyperglycemic events. We are seeing this day in, day out, and we're doing this every day with our population. Meal skipping leading to hypoglycemic events. That midnight snack, you didn't get up to take it. Well, let's tell you how important that is, because otherwise next morning you'll be in a world of hurt. Breathing difficulties as early indicators of COPD flare-up. Etc., etc., and whatever the question wants to be, if it can be tied to observations made in the home, we will tie it back and forward reason to establish that connection. I'll end with a case study. This is a 70-year-old female with COPD, and this is the individual's overall adherence to the care plan. Pretty good, pretty steady, approaching almost 100%, does everything she should be doing. But there was a period somewhere between 40 and 45 days into the program where she did miss a few critical meds for a few days in a row. Never mind, she picks herself back up and she gets back to her good adherent behavior. But we also do query every single day, how are you feeling? Just a simple question on a 3-point scale. Same as yesterday, better than yesterday, worse than yesterday. And starting about that period of time, we noticed that she progressively kept saying worse, 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 worse. That was the first clue that something wasn't going on right. The second clue was after a few days of not feeling well, she started to report my breathing's harder. Because again, we ask periodically, no, actually we ask every day. The care plan is completely customizable. And so we detect a labored breathing. We detect a worsening cough. But the number of triggers, the number one triggers that was in our protocol, whether the O2 sat fell below a threshold or not, never happened. And there was a hospitalization event around day 56. But now we have changed our protocol to also look at I'm not feeling well as the first indication something's wrong, labored breathing as the second indication, worsening cough. So it is all this stuff that's happening in the home that we can harness and do that timely intervention. And that is how I feel there's a fundamental opportunity here to reinvent the way we do chronic care. With that, I shall just conclude with saying that the health data is ubiquitous, and that's a great thing. There is clinical data in the electronic health record system, there's claims data, and then there is all this data that the wearables and other sensors are collecting. They need to be harnessed for real-time decision making. And to the largest extent possible, that those data need to be processed automatically. That's where artificial intelligence comes into play. The intelligence community has been doing this for an awful long time. I mean, yes, lots of people are sitting there watching the predator data, but there also is an awful lot of automated reasoning that's going on. And connected coordinated care is the future of chronic care management. We will learn to do it, and then we will excel in chronic care management just as well as we excel in acute care, and we would have walked the spectrum of that which will cause us to be ill. And that's it. She had her hand up.
I have a bolder goal, which is chronic disease cure.
Yeah.
Reverse engineering. I actually think it's quite doable with what we know about genetics and toxic triggers. So is that a future goal? And then I ask everybody, When will you include dental? Because it's huge.
I agree. Dental has huge early indicators around diabetes and its transition into heart disease. We'll add dental anytime. We can do that. Okay, I'd love to talk to you. My team is back there. Would you, if I don't connect, please? We will add dental anytime. We just added depression. So we've got COPD, pneumonia, hypertension, diabetes, heart failure, and depression is what we're tackling. We will add dental in a heartbeat. Because it is about the totality of care. You can't miss out. If you miss out on clues, you are taking risk. And if you can avoid taking that risk, that's a good thing.
You said that you're going to notify the care team. Now, there's alarm fatigue everywhere. How do they know exactly if this alarm requires immediate attention?
Yeah, so that's built into our protocol. So our customers tell us what notifications they want to receive and what they want to be told about that situation, and it's a personal choice. Many doctors are not choosing to get the hypoglycemic alerts, but probably the COPD flare up and the fluid retention flare up. So they choose that based on how they want to practice medicine. But what they are doing is that ever so often they are reviewing our dashboard to understand what has happened in between the adverse, what we call the adverse events at home. And the population analytics, of course, tells them that we cluster the population into good adherers with good health, good adherers with poor health, poor adherers with poor health, which you would expect, and poor adherers with good health, which are people at risk. You do want to keep your eye on them.
So the cost of putting these sensors in a patient's home to gather the data, is that borne by the insurance companies, the patients themselves, or some other third party?
So we have 4 customers right now, and this year we're experimenting with the different types of customers. So we have an ACO who is bearing the cost. We have an independent assisted living environment that's putting this in every resident's home, because they want to have a clinical baseline so that if something bad presented itself, they have more data upon which to make a decision as to whether to send this person off to the emergency room or not. We have a couple of government programs, Medicaid. We're really primarily going after the dual eligible population, children with disabilities, coordination of their care, education, social needs, multiple specialists, while you're trying to teach this child to be as independent as they can possibly be as they go into adulthood, because as soon as they cross that 21, the social services just go away. So it's Medicaid, Medicare funding that is funding this, either through an ACO type incentive. We can go to the private pay market, but we're not doing that right now because we want the clinical setting to take note and start to change our culture.
How successful have you been in getting the patient to remain adherent?
Yeah, so I'll talk about 2 things. We look at usage, and we have patients who've used this system pretty much every day for 2 years. So there are the patients who either fall in love with it, like we do with our cell phone. We don't leave home without it. It is the way that they stay in command. And then there are people, we probably lost about 30% who would say, it's not for me, my care isn't complicated enough, I don't worry enough, my children are not worried enough. It's a variety of factors that get someone to glom onto this as if it was their life preserver. So those who do, use it indefinitely. We've lost through the system, and we've lost a few, used it till the last day of life. And it really is because we make it fun. Your family pictures can be uploaded by your family members. We're adding gaming this summer. We just want it to be a assuring and engaging environment. Did I answer your question, Phil? Back there?
So you're saying that the care plans are customizable for each patient. Did you have some sort of like a baseline care plan depending on what the condition is for that patient or the set of conditions?
So we have certain portions of the care plan. We have baseline monitoring. We have the standard recommendations, but the meds, of course, is the biggest part of the base plan, of the care plan, and that is purely customized. So behaviors around diet, exercise, and symptom monitoring. We have some standardized component that one can just choose, but then customize and tailor from there on.
In that last slide you had around the COPD condition, is that the typical experience that you see, that type of slowly sliding curve as opposed to something steeper?
Yeah, that's what we're seeing. We're discovering amazing things about how gradual all of this is. It's just that it feels sudden to us because we missed all those gradual indicators.
Does your system address transition of care from hospital to the
Yeah.
handing it over to a primary care physician?
So our first deployment, the ACO did use it as a transition of care because they were trying to avoid the hospital readmission. So yeah, the patient consents in the hospital. When they go home, their care plan is already there. The first home visit, the device comes to their home. They are trained, but we are about longitudinal care. None of them have stopped using the system, so we go from transitional care to long-term care.
Does the primary care get notified immediately?
Yes, that's actually been the greatest benefit. It has been astonishing to me how much in the dark the primary care physician is as soon as an acute event happens. I don't understand that. It's not right for anybody. So yes, so notifying the primary care physician, no matter who made the decision to admit or anything, is what we do. All right, well, thank you. Oh, I think there's one other question. Do I have time to take one more question?
The caregiver accepting this, because as I know, the primary doctors are paid per visit. They're not paid by emails or text messages.
Sure.
So how are they accepting this?
Yeah. So the primary care physicians are not the primary users. It is the care team, which an ACO, pretty much every ACO is now setting up a care team for complex care, high-risk care management that is using the system. But as of this year, Medicaid is reimbursing primary care physicians about $43 per patient per month to provide this kind of oversight on medication adherence, medication reconciliation. So it is becoming that it's also going to be allowed fee for service. Okay. Thank you.
Thank you, Piala. Our next speaker is John Moore. John is the CEO and co-founder of Twine Health. He's a physician, he's a passionate technologist, and he's also a former Qualcomm Tri-Career judge at X Prize. John is also my friend. I met John 2007 or 2008 at the MIT Media Lab, and he was hosting an IEP class. And I really loved his class, and I was actually inspired to do the same thing. And that's why, one of the reasons is, that's why I started Health Innovators. So where John left off, I picked up. Please join me in welcoming John Moore.
That's cool. Now I know. Well, thanks for having me. My name's John Moore. The work that we're doing at Twine Health kind of complements what Mike and Piale talked about. My story is 8 years ago, I was a practicing physician, and I became very disheartened and even embarrassed with my ability to really engage patients deeply in their care, to the extent that people today, in this information age in which we live, they really want to be involved in decisions. They want to not just be at the center of their care, they want to be leading it. And the tools that I had available to me, the system in which I worked, was incompatible with that. And the two talks that you just heard are a really big part of that direction of taking data and getting us away from just thinking about the computer and thinking more about the person. And what we do at Twine is really focus on the psychology and the learning science behind how do you get patients so deeply involved in their care that they're essentially leading it. So if you look at this, the picture here is that this patient is really marginalized. And in addition to the fact that we're switching from acute disease to chronic disease, the additional picture is that if we want to succeed, we need to embrace the power of every patient out there. We need to make them part of the healthcare ecosystem instead of this healthcare system that's just about the clinicians. So what that future really looks like is not just the patient at the center, but the patient driving their care, working with different providers, nurses and nurse practitioners and doctors, with different coaches. These are the extenders, like the medical assistants or health coaches or patient navigators, and with family and friends, and leveraging the devices that they use, but taking it a step forward so that patients are actually driving the agenda of their care. They're involved in shared decisions about creating their care plans. They're pushing their providers to take steps to the next level. And we built what we call a collaborative care platform. Twine allows patients to really effectively collaborate with their care teams in that time between visits. And I'll show you how much different this healthcare experience is and dig into some really quantitative data about how different the results are. Particularly, I'll dig into hypertension as an example. So what the collaborative care platform looks like is a set of interfaces on top of this collaborative system and services for patients to really learn and self-reflect and build self-efficacy, for family members and friends to provide social accountability and to support patients, for the extenders to have the intelligent tools that they need to provide the right care to the right people at the right time, and then tools all the way up the provider and organization level to help them turn the knobs on this new value-based care system. We measure every bit of time that every personnel in the healthcare system spends with every patient and correlate that with outcomes so that then you can optimize that system. And the key part is there are a lot of different tools out there for patient engagement apps. There are a lot of systems out there for care management, but very few, I think Bialy's is one of the other few that's designed from the ground up with both sides of the equation there. What it looks like is a really dramatic, different experience. So let me show you a quick video that will walk you through what that looks like.
You know, I'd really like to lower my blood pressure.
Great, let's make a plan.
Hi, Ellie.
Hey, Grandpa, can we finish my bag tonight?
No, I'm sorry, Ellie. I have to see my doctor this afternoon, so I'm gonna have to stay late at work. What if we finish your bike up over the weekend?
Okay.
So I'll show you. So I'll show you real details. I'll show you a live demo of what things look like on the clinician side. But I really want to focus on what's different about this patient experience. We spent 6 years at the MIT Media Lab with the Joslin Diabetes Clinic, Massachusetts General Hospital, Mayo, Boston University, working from HIV to hypertension, diabetes, really getting at the root of what helps patients understand their diseases better and engage in their care very differently. So Tony engaged in his care a very different way than we're used to, and very above and beyond our expectations that we have in the medical system for people. And what's really different is starting with that shared decision-making process, giving Tony a voice and giving him ability to really compare and contrast different options in his care, whether diet versus exercise might have a greater impact, and quantitatively how much that impacts in what period of time. So he has very concrete expectations. And that drives tools that don't just remind Tony what to do, but to help him self-reflect and learn and cherish and revel in that accomplishment, doing so with people that are important to him. And as you saw, his son also chimed into this process. So having that real-time connection with other people that he brings into the fold as part of his care team. And then allowing caregivers from the healthcare system, in this case, a health coach who's practicing as part of the organization, to deliver care in real time in the context of his life as he needs it. And really, the value proposition that gets our patients to dive in and really put in this effort is the fact that they're able to achieve their goals quickly and move on with their life. Right? Patients don't want to be burdened with this for extensive periods of time. They want success. They want big wins in short period of time. And in addition to them really telling us that this type of experience is what they've always wanted in healthcare. Right? They've had a doctor that they love, but in the past year of having this new kind of connection with their care team really dramatically transformed that, or even saved their life, that with top-notch institutions like the Brigham and MGH and the VA, Iora Health and others, we're showing hard data about how different this kind of care performs. So for example, in high blood pressure care and hypertension care, the norm is an office visit every 3 to 6 months. And the norm is of those uncontrolled patients, only 30% of them will reach goal in a year. So pretty abysmal outcomes. And that's predominantly because 30% of patients never fill the medication, and 50% of them stop taking it in the first year. And that's predominantly because we didn't appeal to their values, to their interests. But when you get them engaged and you add an extender on the other end of this that provides between visit care, it's almost 100% improvement in outcomes. The problem is it will bankrupt an organization. So most organizations can put a nurse or a pharmacist on the other end of the phone, of a secure messaging solution, and they can simultaneously manage 100 patients. That means they're spending about $1,000 per patient per year, which is more than the cost benefit that they gain. Our data now with Twine shows that we're helping 92% of patients reach goal within only 3 months. So in a quarter of the time, 3 times better results than the standard of care. Because we track every minute of interaction with every provider, every extender, with every patient, we can do real-time ROI analysis there. And we're showing that it only takes 12 minutes of coach time per patient per month to provide this, to support the patient in this exceptional level of care. So that's a 5x improvement. By the end of this year, we think we'll have that to 1,000 patients. And we've also shown data that there's a 2/3 reduction in office visits. So that's not just hypertension office visits, that's all cause. Because when you get the patient involved in their care, proactively involved in reaching goals, they behave differently, right? They behave much more proactive manner, they address problems earlier, they have an open communication channel, and they get the job done. Yes, please.
The coaches, are these the community members or are these health professionals?
It's a mix. So in our organizations with whom we work, it's anyone from a doctor to a pharmacist, to a nurse, to a medical assistant, to a non-clinically trained health coach. Currently, we see no correlation between that person's academic credentials and the patient outcomes. And that's because predominantly what we're dealing with is behavioral issues, right? Provided that a physician was involved in the care plan at some point, 75% of the time, that care plan that's not working, it's in the EMR, but no one's helping to support the patient. 75% of the time, if you put a human on the other end of that, who's friendly, and sits on top of these learning tools, that patient will achieve the outcome without a change in care plan. Only 25% of the time will it require hitting the pharmacist or the nurse or the doctor to make an adjustment in the care plan. That just says how much we over-medicalize our failure in chronic disease. It's really so much more behavior. And patients just need support, and they need to feel like their opinion and their input matters. When you do that, they take off.
Is there accountability with the community members?
Yeah, so the social accountability here is one of the biggest drivers of patient behavior change, right? Because the fact that there are family members, there's this coach that took the time out of their day to really do shared decision-making with the patient, to be there for them, have an open conversation. The entire role of the patient changes, right? They're used to getting someone mean on the other end of the phone that won't give them an office visit. Now there's someone there that replies to them within 24 hours. They feel indebted to them a bit, and that drives a lot of the behavior change.
Thank you.
Yeah, no problem.
I won't ask about medical this time. So what I love is you're nudging the patient towards better behavior. You also flip this to nudge the clinicians.
Yeah.
Because where I'd like to nudge the clinicians is to look more at genetics and toxins, because there's nothing that I experience that influences behavior more than having inflammation that wrecks everything.
Yeah, so maybe that's one piece. One piece I'd like to talk about is the fact that behavior change is not just a patient issue. It is we have huge inertia in the medical system around lack of connectedness with our outcomes. So what we're building is tools that in real time allow the performance of different care team members to be compared with each other. So what's the patient satisfaction in my panel versus someone else's? What do the outcomes look like? How active are the patients? How much time am I spending per patient? So you can correlate cost. So now having this kind of real-time insight allows individuals to compare themselves and look out for best practices and try to improve. It also allows organizations to figure out how to best train and share best practices within their organizations. Yeah, really important as we enter into value-based care. If you don't have this kind of insight, you will never win. Right? It's like Walmart trying to stock its shelves without understanding what products are on the shelves and where they're moving. That's where we are in healthcare. We don't know who spends time with whom and how that correlates with outcomes. So we instrumented that whole system so that we can measure and improve all the way along the way. Yes, fire away.
I was just going to supplement what you said about the non-clinicians. I think the primary care group
Yes.
did a study with ARC, AHRQ, and they found very good results with the non-clinicians
Right.
for the patients. And then also at HIMSS, Alina Health did a project.
Right.
They also said they had actually better results with the non-clinicians.
Yes. Yeah, there's about 10 years of research there. The best is when you have a tiered system where everyone practices at the top of their license. That includes the patient, right? Patients don't want to be told what to do, right? They want to be involved. And coaches don't want to be just blindly following rules. They want to be practicing an art and helping people and feel gratified. Nurses and doctors, they want to be working at the highest level of their license, really looking at the challenging problems, adjusting the more critical medications. And when you can arbitrage that labor, really measure it all and see who's doing what and help the organization improve, that's when you maximize the benefit for everyone. And each organization is a bit different. It depends on the disease. It depends on the demographics of the patients. But it's all possible. You just need to be able to measure yourself and have those open lines of communication. How are we on time? Because I can decide whether to show a live demo versus just field more questions.
Sorry. You can add those.
You can keep going because you can. There's going to be a panel discussion at the end. So you might
Because we
have to-
fielded some of the questions. Yeah, maybe I'll show a quick live demo.
Yeah.
I think people might like to see that.
But you will get a chance to answer the questions at the end.
Yes, great. So let me just. So this right-hand side is patient's cell phone, tablet, and the browser. We run across all platforms. Left-hand side is a coach's dashboard that can also be used by physicians and other team members. But Clarissa here is this coach who's logged in, and Clarissa has a panel of patients. She wants to make sure everyone in her panel has a, well, hopefully the Wi-Fi will cooperate here. Every patient has a personalized care plan. And so Peggy is one of these patients that's logged in. And they can choose different outcomes that they might want to optimize. We're in the process of adding hundreds of different outcomes so that you can create care plans no matter what the condition, whether it's HIV to COPD or asthma or depression. Here, you can set a personalized goal with Peggy, in this case for her blood pressure. You can set personalized critical values so that every patient has a really plan that's really honed to them. Now it has tools for Peggy and for her team, I'll blow this up a little bit, to compare different medications versus lifestyle changes. So here Clarissa might say, hey Peggy, we could start the starting dose of lisinopril, which is part of the JNC8 guidelines that Twine lets you pick from really quickly. And you'll get a 5-point drop in your blood pressure in 2 weeks. Really concrete expectation. People don't get that in healthcare. What they get is, take this, your blood pressure will get better. And they go home and they say, well, my blood pressure, does that matter? Is it getting better? How long is it going to take? Now we're concrete, but they can say, well, regular exercise, you'll get a bigger benefit. It'll take a little longer, it's a little more work. So they can have that trade-off, choose something in the plan that Peggy really believes in. They can crisp up that plan. Well, when during the day are you going to do that exercise, Peggy? What's important to you? How many days a week? Let's set a bite-sized, achievable goal of 1 day a week. And let's make it really personalized. So it's not regular exercise. You live across the street from Lincoln Park, and it's a 1/4 mile around. So now we have a really crisp, concrete, personalized plan for Peggy. When you save that plan, it just synchronized to her device on the right-hand side in real time. So before you leave that conversation, she has now an actionable care plan. And if I go back to the dashboard here, as Peggy uses smart devices that she can buy from Best Buy, like a Wittings or an iHealth or another, or she self-inputs this data, that data will flow in real time over to Clarissa's dashboard. Same thing with her medication adherence, her lifestyle change. As she sends messages, that data will flow. And now Clarissa, for every one of her patients, has a heads up information about their adherence. Peggy's in the green here, about their latest vitals or key information towards their goals, about their messages. Clarissa can video call to Peggy. Silence this. She can video call to Peggy on the other side and have a conversation with her and co-navigate her record while they're having that video call. Might be some Wi-Fi issues here. But she has this heads-up information about what's going on. But Clarissa can't do that for every patient and look through them every day. So Twine has the intelligence where she can go and say, show me all of my patients who are struggling with adherence to their care plan. And now she's just narrowed in on those patients. Or she can say, show me those patients whose plans have expired, right? They set that expectation of when they were going to reach the goal. Now we can focus into that with them. Or she can look at, show me all of my uncontrolled hypertensives, and then narrow down even more to those that are uncontrolled hypertensives with adherence issues. And then she can send out group messages to those cohorts from a pre-created library. Oh, here's an information about how to measure your blood pressure at home. And now that's been sent to all of those patients with video content that helps them to learn even more. So now she has all these tools at her disposal that really help her to provide the right care to the right patient at the right time. And as I said, it's measuring every minute of time that she spends with every patient. So if I go to any of these patients, like Jackie here, I can see exactly how much time every member of the care team has spent this month and previous months. So we can automate CCM billing. That's the Medicare Chronic Care Management Code. Because we're tracking all of that in real time, you just do your work, and we can automate the billing for you behind the scenes so you can get paid for all these interactions. Thanks.
There is panel discussion at the end, so if you have any questions for John, you can ask him later at the panel discussion. Well, welcome back, everybody. Our next speaker is David Lebazinski. David is a consulting physician at I Get Better. He's a UMass alumnus, and he went to College of Holy Cross, and he's the alumnus of Holy Cross. Please join me in welcoming David Lebazinski.
Thank you. We're going to be continuing a very similar theme here. I'm the only physician that works for I Get Better. We're a small company that provides a very nice platform for helping to maintain the virtual relationship between physician and patient, which is evolving tremendously in this day and age. And I think it's my job, since I work with some really tremendously talented individuals, sometimes to give them a clinical perspective about what the doctor actually wants to see and what he or she doesn't want to see sometimes, to kind of prevent that fire hose of data from coming back from the field. Doctors don't necessarily want to know everything. Usually they have a pretty good idea in mind what they do want to know. But we also use our platform to give a significant measure of control to the patient as well, so that they can invite family members to view their care plan that doctors have assigned to them. And they're in control of who gets to see it and the data that comes back from it. So it's a complicated platform. There's a lot that we do. It's a short period of time, but I'll try to get to some of the highlights. And this was a slide that probably worked better earlier in the afternoon. It's a little complicated. Our CEO from MIT loves this slide. For me, there's a lot going on here. I'm a physician, I don't even use a smartphone. I use a flip phone. Basically, we have a platform that's accessible anywhere the patient can use a browser. So whether it's on a smartphone, whether it's on a PC, laptop, whatever, they can access our system. If they don't have anything, and if we've deployed in places where patients are not IT savvy, we'll give them an iPad mini with which they can access our system. To that iPad or smartphone, if the clinician wants, they can pair a multitude of different devices. As long as they're compatible with a middleware company that's out there called Validic, which allows us to plug in our API to their company, we can get the data and deliver it to the clinician. Everything is cloud-based, as everything seems to be in this day and age. And within 30 seconds of taking a measurement, clinicians can actually see the data. And we've devised our systems that clinicians, similar to Twine, can choose when an alert is triggered. And those patients are brought to the clinician's attention first and foremost. I mean, a lot, very similar to a lot of the triple aim themes that occur in these days. Our system is designed to improve patient population health, lower costs, engage patients, not only patients, but their family members as well, and ultimately reduce emissions and keep everybody happier, obviously. Our first deployment was at Mass General Hospital. It was really a feasibility study that we did a couple years ago. We enrolled 20 CHF patients, and we tried to keep it simple. They were provided through their Department of Cardiology. Keeping it simple is important for senior citizens in particular. Most of our CHF patients were senior citizens. Simple is good. So they were given this was the kit they received. It was easy. Get up in the morning, use the bathroom, step on the scale. And the only thing that needs to happen is the iPad needs to be in the same room as the scale when you step on the scale. If they do that, the clinician can see the reading within 30 seconds. They don't even have to open the cover to the iPad. The blood pressure cuff, a little more involved. They have to hit the button on the edge of the cuff. The app opens automatically. It's on their arm. They hit the green start button. It inflates automatically, and then you can get the reading within 30 seconds. And then they were asked a couple simple questions. Did you do a little bit of exercise today? And did you take your meds as you were supposed to? And to be honest, patients were deployed. They were asked to use these devices daily for 3 months, continuously, once a day, every day. And I was hoping going into it that we would get maybe 50% of the time that they were enrolled that would use the devices. And then they were given an exit questionnaire. And they all felt that it was easy to use the system, they all thought it was great, and all that's nice and fine and dandy. So they enjoyed using the system and they thought it was easy to learn. And this is one of the nicer slides, which was surprising to me. So for the 12 weeks they were enrolled, not surprising that first week with shiny new toys, they logged in most frequently. But then the cool thing is weeks 2 through 12, it was sustained. They kept, for 3/4 of the patients, they still logged in every day. In fact, of all the days that they could have logged their data, all the patients throughout the study, 89% of the days they actually logged their data. I was shocked at that, to be honest with you. They had one CHF-related readmission that compared to 23.4%, which was the Mass General normal 30-day rate. Not statistically significant, obviously, with just 20 patients, at least suggestive that it's trending in the right direction. More importantly, 80% of the patients felt their CHF was better controlled as a result of using I Get Better and following their own data. I mean, with a little bit of education to say, here's why checking your weight makes a difference. That means fluids being retained. And then they can say, hey, okay, I see why it makes a difference. On top of that, if their weight trended up, they knew they were going to get a phone call from the nurse practitioner saying, what have you done? Why are you falling off the rails? After that, and we had success with Mass General, we then moved on to Signature Healthcare, which is Brockton Hospital, basically. And that's a different group of patients. They serve a lower socioeconomic population. They were having problems with a number of patients with 30-day bounce-back admissions. With the new CMS mandates, those were unreimbursed admissions. And they actually chose about 25 patients, not based on clinical severity of their CHF, they chose them based on financial reasons. These patients were kind of training them financially. So most of the time, right after an admission where they were brought in, they were diuresed, and they were ready to go home, they took our system. You can enroll a patient in our system from the bedside. It takes all of 30 seconds. You give them a scale, blood pressure cuff, show them how to use it. Again, it's very simple. And then they go home. And they have a nurse practitioner who previously was calling all their CHF patients in what's called their Homeward Bound project every day to see how they were doing. With our system, they don't have to call them every day. They go in, they log in, they see who's triggered an alert for that day. Usually it's about 2 or 3 patients. They need only call those 2 or 3 patients. And they've gone from taking a full-time person half a day to track everybody down to 20 minutes every day on average. And patients have learned that when they go off the rails and they have a little too much salt over the weekend, and on Monday or after a holiday, their weight is 4 pounds higher than it was previously, they know they're going to get a call. They know they're going to get bolused with Lasix, and they've changed their habits. As a result, of all those patients, 25 who were previously problematic, they didn't have, in the year that we've been deployed at Brockton Hospital, not one of those patients had a single CHF-related admission. Not just 30 days, but none. In fact, we met with the CEO in September, and he was kind of joking with us that we kind of cost him about $700,000 or $800,000 of revenue because we wiped out what would have been the reimbursed admissions. But they got a bonus from CMS of over $1.5 million for actually lowering their 30-day readmission rate. So the system more than paying for itself. And more important than that, the patients were home. They weren't bouncing back to the hospital. They were happier. By having family members also involved in the care and seeing if a father or someone in the family, whoever you want to invite to see your care plan, was trending in the wrong direction, oftentimes they were proactive and they would call the primary care doctor and say, hey, you need to see my dad or something, even before the patient would want to be willing to go in and be seen, let's put it that way. So the families were involved. Since that time, we've deployed for a number of different conditions. Not just CHF. CHF was first because that's what CMS mandated and it was kind of easy to do. But now we're in different centers for hypertension, diabetes, orthopedic programs, total knee replacements. Hypertrophic cardiomyopathy is one of our newer ones. That's over at the Brigham. Callum McRae came up with a different idea. For these patients, they have big, thick heart walls. It's mostly genetic. And you have to relax the heart and give it time to fill. If the heart beats too fast, you can't fill it and their cardiac output goes down. So when these patients are diagnosed, they want to put them on a regimen of often 2 or 3 different medications designed to slow the heart. The old-fashioned way is you bring them in, you start them at a low dose,
You send them home, you bring them back in 2 weeks, you ask them how they felt, or did they have any symptoms, increase the medication, send them home, come back, and so forth. It's labor intensive, it takes a while. I trained at UMass. Patients in Worcester and Central Mass don't like coming into Boston. That's like too complicated for them, it's too expensive. And a lot of them are busy. Some of these hypertrophic cardiomyopathy patients, they have lives. They don't want to be going to the doctors every couple of weeks. And that whole period, by the time you get them up to speed and therapeutic, can be like several weeks, several months. So the first patient they enrolled was perfect. He was from the Cape, he was a contractor. He didn't want to come to Boston all the time. They brought him in for the first visit, we enrolled in the program. The doctors just wanted to ask a few things every day as they were ramping up their medication. Do you have any chest pain? Do you have any palpitations? And they qualified it. It was a selection of 5 different answers they could give. Any lightheadedness or dizziness, and they gave him a blood pressure cuff to see what their pressure and heart rate was. And if every 2 or 3 days they didn't have any, horrible symptoms, and their blood pressure was good and their heart rate was good, they would bump up the medication remotely. And so they took what was a 2 or 3 month period to get them therapeutic on the drugs where they want them to be, went down to like 2 or 3 weeks. So, and the patients didn't have to come in. So they were thrilled. And it ended up working out pretty well at this point. That's kind of the way our system is designed. We have a platform with our care plan editor that it's simple to use for the patient. They log in, they choose their own username and password. And with our care plan editor, well, let me just go through here. It's simple. There's an activity section, and that's if someone's on like a PT program, they're the exercises you're supposed to be doing on this particular day, and it rotates depending on when the orthopedist wants you to see certain activities. Week 1, week 2, week 3. Announcements, teaching that can be done here, messages that can go specifically to you, not just globally about CHF and whatever diabetes condition we're talking about. But we've had some patients who, if they're on Coumadin and they like to binge in strawberries in June and their INR goes way off, we've had clinicians say, okay, I know for this patient they need to limit their strawberry intake to 1 cup a day, or whatever it is, 1 cup a week. And they put messages on it like this. With the ease of use of the care plan editor, that's what the clinician can do. So they're not just giving information to the patient, they're giving information that's clinically important. Those strawberries were messing up the INR. They can log their progress, obviously. There's multiple different ways clinicians can choose to get data. They can ask them text questions and get text answers. They can ask simple yes and no questions. They can have slider bars on a scale of 1 to 10, whether it's they want to ask about nausea or pain. Our orthopedists ask about pain in different ways. What's your pain when you're bending your knee? What's your pain at rest? What's your pain with activity, etc. Whatever the clinician wants to ask, our care plan editor gives them the chance to do it. So they can have, generally speaking, a global care plan that they apply to most patients, but then they can tailor it down to the level of an individual patient. And they can do it at any time. It's not just at the beginning, but any time they can go back in and tweak it. When the clinician logs in, he or she sees in the box on the right what patients have triggered an alert since the last time that you logged in, and then you can go to their data. Stuff that's too high or too low is in red. Again, the parameters are set by the clinician. You can put annotations in there so you can say that on this particular day I increased the patient's Lasix or what have you. And this is kind of the guts of our care plan editor that the clinician can use. It's just a series of cards. And if you click on an individual card, there's the text that you want to show the patient. You can choose the frequency that it appears. You can make a card for anything. These orange cards are activity cards, something you want the patient to do. Blue cards are announcements, something you want to tell the patient. You can put a link in there that you want them to go to a certain web page or see a certain video you thought would be good for them. And then the purple cards are measurement cards, often tied to a device, but not necessarily. It could be a question that you just ask them, what's your nausea level for today, what have you. And then you choose the parameters that you want to set for normal for that particular patient. And again, from the patient's interface, they can invite other family members to see their care plan and follow their data, and then they can uninvite them at any time that they want as well. Patients in complete control, and they can invite other physicians as well. And they can also communicate with their clinician as well. If it's
it's not urgent, obviously, and you can say whatever it is, whatever message they want to send to the clinician, and the clinician can communicate back. So that's a very brief overview of our system. Questions?
Now, the scale is talking to the Bluetooth in the iPad. That's where it has to be in the same room.
Bluetooth generally doesn't work too well if like the scale is in one room and the iPad is in another. That often Bluetooth connection doesn't work. So for simple practical purposes, we tell them to keep the iPad in the same room as the scale. And the iPad has a Verizon wireless signal, so that's how we get the data.
Why can't the tool just upload the data using a Wi-Fi?
That was an initial thought of ours, but our experience is that a lot of patients, especially senior citizens, may not know what their Wi-Fi password is. They are not, I mean, we're dealing with patients who are really sometimes not IT savvy. I mean, we had an issue once where Verizon reset their signals to a different frequency, and all you had to do was turn off the iPad and turn it back on and reset. Just the act of describing that I did over the phone to certain patients to find the button on the iPad to turn it off, and some patients were like, well, it's not round, so it's not really a button. I mean, God bless them, but you really do have to keep it very simple. That's why the interface that we showed you, I mean, we'll go back. This is not a lot of bells and whistles in the interface. It's very simplistic, but senior citizens in particular like simple. Withings, it works for Withings. Withings is wonderful, and they have a very cool, slick app, and they're a French company, and they change the look of it with different fashion seasons, literally, I think sometimes, and senior citizens hate that as our experience. To go from a purple interface to a blue one to a red one confuses the crap out of them. They're like, we just want simple. And that's one of my jobs, which is to tell our guys sometimes, keep it simple. Simple is good when you're trying to get information back. For the younger hip generation, a new interface is cool. For the older folks who are not used to iPads and so forth, it's a challenge. So we keep it simple.
Sounds like a lot of work, the care plan editor for the clinicians.
Well,
how is that working?
Well, number one, we try to make it easy to use. But number two, generally, most clinicians, once they come up with their own little care plan for CHF, they deploy mostly the same care plan to 95% of the patients. And then they'll tweak it for the rest of the 5% to add a message, subtract a message, or whatever. So they're not overhauling the care plan every time they deploy it. They're just tweaking it here and there, but most patients are getting the same one. They also play into a little bit of the doctor's egos. If you're working for the Brigham, you don't necessarily want to use the same care plan that you use at Mass General or Johns Hopkins. You want your own care plan. It's mostly the same. But they have their own, and once they have their own, that's what they want to deploy, usually, for the majority of patients.
So let's say Brigham, cardiology are all deploying the same care plan?
No, they don't have to. Each physician can deploy their own version of their own CHF care plan or orthopedic care plan, whatever they want. That's the beauty of the care plan editor. And so each physician will have their own library. And they could even have orthopedic care plan 1, 2, 3 for total knees, depending on how they want to, whatever slight changes they want to have between them. They can have as many as they want in their library.
My question is regarding user interface. It's all in English. Do you have to put out in Spanish?
Not yet. That would be easy to do. As soon as we have someone who really wants to do it. I mean, we're still an early company, so we're still proving our efficaciousness. Efficacy, and that's just in English. Once we do that, then we'll happily venture out to other languages. Anyone else?
What do you think wearables will play in the future?
Depending on what the clinician wants, basically. Some clinicians don't want it, and some clinicians do. Some clinicians, the last thing they want is to know how many steps somebody took, because they're like, it depends on what the clinician wants. At the Brigham, for the hypertrophic cardiomyopathy patients, they are giving them a little Withings Pulse O2 to actually figure out how many steps they're taking. They're not using that as their first line of defense as to saying how active they are every day, but just as kind of a global indicator about whether or not their activity may have dropped off. They're using it. It's up to the clinician, basically. And it's a work in progress with the patient.
I mean, we've had clinicians say, okay, we won't give you a ton of messages every day, but can you just use the scale every day so we can follow your weight if you're a CHF patient? And they can have that dialogue back and forth between clinician and patient to say, okay, for this person, that's all we're going to do. So it's up to what the clinician and patient both decide. But most clinicians, I don't think, want a whole lot of data unless they think it's clinically relevant. Because they're busy. They don't want to sit through a whole bunch of stuff unless it's going to change the medical management. But they have the option. Okay.
We're having a panel discussion.
Well, this is our panel discussion, folks. If you have any questions which you didn't get a chance to ask, please, this is your time. I know John didn't have time to take questions, so please, if you have any questions, feel free to go ahead.
Sorry, my voice sounds low, but so we've had obviously at least 3 of you possibly have heard, we have some overlap in the solution sector coming up with. I can think of several other companies as well that are here, and certainly there's also been a push from the insurance side and from the corporate side to design and to have wellness platforms and behavior modification platforms. So I'm curious. We're at such an early stage in this process. How do you see this playing out in terms of the patient and provider platform versus the employer and employee wellness platform?
Yeah, so we've actually had some discussions with different employer platforms that are predominantly focused on wellness, and they're predominantly focused on presenteeism and work performance. And many of them are looking to do partnerships with companies like ours because they're starting to get asked about chronic disease, because their offerings don't get that deep beyond the step counts and the challenges, which are very important, right? The wellness part of it, getting proactive, being preventative is an important part, but they're starting to want to close the loop. And that's because a lot of employers are either creating on-site clinics or contracting directly with new types of providers, cutting out the insurance middleman for primary care. So they're starting to want to connect their wellness platforms with actual disease management and more medical platforms. So it's an open opportunity for companies like ours.
But I would just add, I think ultimately you have to prove that whatever you're doing pays for itself and that it's worth whatever the cost is. I mean, none of this can be free. So, do the benefits outweigh the costs? And no one knows the answer to that yet.
Yeah. Okay, great. So my next question is from a technology perspective. I know many of you are having hosted solutions or in-cloud solutions rather than relying upon a particular medical system to do the rollout and implementation themselves and host something themselves, because that adds a lot of stress and a lot of their environment. What are you doing currently to make sure that you're complying with things like HIPAA standards or any regulatory considerations that the providers have?
So ours is a cloud solution. We have architected the solution from ground up to be the data is partitioned off in ways that putting that puzzle together as to whose data this is, to be able to construct a health picture that is also associated with the personally identifiable information is rather difficult. So this whole notion about can someone hack in and reconstruct and what can they find out that would be sensitive and should be protected is built into the architecture. Legitimate concern but we are thinking about it every day. I mean, from whether it's password changes to just keeping data just so spread out that you really just wouldn't know how to piece it all together. Those are all techniques we're using.
Every one of us in all of our contracts has to adhere to our HIPAA policies and procedures. And you have to sign a BAA with every contract that you do. So it's just part of the business. But shouldn't be seen as an insurmountable or egregious need. It's very doable to go above and beyond HIPAA standards and really be focused on data privacy and not have it bankrupt your company. So don't let it hold you back, but make it a priority.
Great. Just part of the business, and one of the first things we do when we start a pilot in a place is talk to the IT team. If they have questions, we give them the answers they want. They clear us. They usually want to know, are we compatible and secure, and do they have to do anything before starting a pilot? Because we can tie in winning MR, and usually at the beginning they don't want that, because that's work for them. So once they hear that we don't need to and that everything's secure, they're happy, and they sign off. Usual BAs are signed. So.
I have one final question. I have a background in health communication, so I'm wondering from a messaging standpoint and other things as well. Are you looking at ways of designing the actual interactions with the patients, with the clients at their homes, at their places of work, or what have you, with being aware of the wording and the level of expertise and the social context essentially that they're in?
The education piece is the piece that we're working most now. So where there our focus is first establishing the context. I think you mentioned that it just has to be relevant to the first concern is it's relevant to the user. If we just keep bombarding them with stuff that they don't see the connection in their own lives, then they'll say, this is wasting my time, it's frustrating. So the first thing is to make sure it's relevant and to be able to explain to them why it's relevant to their situation. That's where we're focused right now, but I see your point about it needing to be messaged in a way that is also heard. So we're focused on relevance, would love to work with you to make sure that's also communicated in a way that is heard. We are using a lot of nudging techniques from thinking fast and slow and stuff like that, but we don't have that behavioral economics expertise within the company. Would love to partner there.
Yeah, looking back 5 or 10 years when human-centered design was not the norm, it's just mind-boggling that anyone would design a product in healthcare that didn't really engage with the user in the design process and figure out it's understandable how we are where we are with most EMRs, right? It's because there was no human-centered design process there. But now, the great stuff that's coming out of these kind of companies is all because the user is king.
One of the biggest problems, and this question applies to all of you, one of the biggest problems is changing doctors' mindset to adopt new technology. It's so hard to first get into the hospital and then changing one person at a time. How did you do it?
I mean, his story's right on. I mean, that really resonated with me about the radiologists.
Yeah, I think, what these guys have done is they've developed a great interface with their patients. We did the same thing with clinicians, right? We understand how clinicians think and what's their workflow. So once we understood that, then we just designed the application around clinical workflow. So we literally have 7,500 doctors using this thing. There's no training. There's barely any support. It's just doctors selling to other doctors. It's the first application I've seen actually in healthcare where you don't have to hit a doctor over the head to use a piece of technology. And I ran an EHR company before this, so I understand about hitting doctors over the head to use a product. So I think a lot of it's just design, right, and clinical workflow. And physicians will do it if it makes their job easier and makes them better practitioners. If it doesn't, you're going to have to hit them with a stick.
Yeah, I think a lot of that legacy of opinion is about products that didn't really deliver on core values and core outcomes that they wanted to achieve. But now we're in a new age where they're taking on new kinds of contracts where they have risk, and if they don't perform, they don't win, right? And now in a day where they're freed up and can bring back that gratification from getting better patient outcomes, they want to see that. So tools like this that start to help them see that on a daily basis, it's bringing back the joy of medicine, bringing back that gratification that comes. People make decisions based on that. I think for our generation of tools, that's going to be the truth. That we're not going to worry about saying that, oh, clinicians are slow to adopt.
And the other piece of the equation, I think, is that the whole ecosystem of caregivers is expanding. So there's the population analysts now who will look at it from the population perspective and then work with the physician to say, hey, I'm seeing some disparities in care. Could we just bring some best practices from here to there? Then there are the patient navigators and the care coordinators, and there were never tools for them to begin with. So the blessing here is it isn't business as usual in that the doctor makes all the decision. It is evolving into a care, team-based care, and then so the tools just fit into the right place.
Next question.
I guess this is for everyone, but can we envision a time in the future where people will absolutely want a care plan, they'll do their genomic data, and they'll plan from a very early age on, much the same as they might do with financial planning? Do you think that your products could help support something like that, where people actually make a plan for their life, for their health, and not just wait till a disaster?
Some people who plan well, some people who don't, and people in the middle. So the tools are, adaptable, but, not everyone's going to.
What if they were incentivized to do it for health insurance premiums or something like that?
Medicine, so often I keep telling people, it's a third, a third, a third. And a third of people fall in both extremes and a third are in the middle. And middle third, yes, you can probably incentivize it, but I guarantee there's still going to be a third who, no way. Well, that's fine. I admire those folks too. Yeah, I think right now we're not giving really anybody the opportunity. So there's a huge percentage of the population that's thirsty for this kind of stuff.
Yeah, they're lucky if they can get a clinical visit summary and everyone thinks that's a big deal.
Yeah. So if you make things easy to use and there's, a benefit to them and however you want to define that, they'll use it. It's all about that value proposition. If it means they don't need to schedule an office visit, they don't need to take off work, and they don't need to come and sit in a waiting room, right, that will change the amount of work that people do because it translates that work somewhere else. But be careful of financial incentives. Okay? There's lots of data that says you will get worse.
The effect of the nudging goes down if you tie a financial incentive. And that feeling empowered. We hear that over and over again that I was trusted to manage my own care. I mean, that's a huge emotional appeal. And again, on financial planning, when a company stopped giving these huge pension plan and you just assume that if I retired after 30 years, I'll be well taken care of, don't worry about it. Well, those days are gone. You are micromanaging and moving your money around in your 401k every month. Well, that's because you were expected to be in control. And I think
I feel that pain.
Yeah, so do I.
On a scale of 1 to 10.
But in healthcare, I think we're moving in that direction where it's not like your physician knows best. You are part of the solution. You're empowered to take care of yourself. If you want to live long and healthy, do this. And with that empowerment comes the desire to manage.
Look at how many people are using a Fitbit.
Yeah.
I think that's the start of it.
Yep.
So, congratulations to all of you for disrupting healthcare. It's very encouraging to see you all together and inspiring. This is a question for everyone. A lot of your solutions seem to have a bottleneck around a health coach or a human person intervening at some level. And I'm wondering, when you think about scaling to other economies where you don't have one health coach for every couple hundred patients, but you really need automated solutions, what you think about the potential for these kind of approaches to scale to, I guess, poorer populations or populations who aren't able or willing to spend like you do here in America.
Yeah, I think in the end, our opinion is that the amount of scale that a single human can provide care to other humans will be dramatically augmented by the technology. So it's the machine support, but it's really the human touch. We believe in that if you take away the human touch, you've lost the compelling part of what drives things. But the machine can help that human, right? We've gone from 100 to 500. The norm now is 100. We think we can get to 1,000 by the end of the year. Next year, maybe that could be 10,000. But we don't believe in removing that human. There are a lot of solutions out here that aren't represented in this panel that believe in total automation. And you know, they have different roles and they may be successful in different things, but I think when it comes to the kind of work that we saw represented here, I think that human touch is really important.
Medicine is still an art form. You can't have almost no patient's disease reads the textbook and appears textbook. If they do, then you have to wonder sometimes about whether or not it's legitimate. I mean, I had a patient once whose angina symptoms were, instead of the usual pressure and going down the left arm, his palms get itchy. Well, who predicts that, Well, at least with our care plan editor, you could ask them, did you have an episode of your palms getting itchy today? That would be that person's angina symptom. Everyone's different, and I don't know of a way where you can just have a simple flow chart. It's an art form, so you need that human factor on the doctor's side, clinician side, interpreting the information that comes back. That's still the most efficacious, timely way of doing things, is to have a person on the other end to see, is this clinically relevant or not? And if you know your patients over time, and hopefully this is a means of allowing you to continue to know your patients and know them even better, there's no substitute for that.
And a piece of the touch is, doesn't have to be the doctor, it can be a family member. I mean, health has to involve human touch because it's a scary place to be when you are concerned and scared. So one of the deployments we're doing, actually envisioning in Maine, we're working towards it, is like the Beacon Village type concept. Your first support might be, a neighbor, or so we think of a care plan and an intervention plan. And the intervention plan can be anybody, but it is a person who is going to connect with you and help you get through it. Systems can't replace that totally. It's not right.
The question there.
Thank you for bringing that up. Our next question is going to be the definition of health, being well, being healthy. And if you taking our social determinants of health, it's accounts for 70% of somebody being healthy or in a particular disease state. So how do you account for that? How do you build systems for that?
Yeah, I don't think you build the system for that, you build a network, right? And you let those people who are part of that network participate. And you allow certain parts of it to be formalized so it can be communicated, but you leverage that network. And that's, in the end, really, the more you get any individual engaged and the more you help them succeed, the more they have a desire to help other people succeed. So they're the apprentice and become a master, and they pay that forward. We see people doing that out on the web today with less sophisticated tools, but then there are patients like me that are building tools to make that more formalized. And then there'll be more and more systems like that allow that community to come together and pay it forward. And I think that's when we've really succeeded, right? Because then that's something that scales exponentially, right? Our chronic disease problem is scaling exponentially. So we need something to defeat it that scales exponentially. And I think it's by empowering that network and helping everyone participate.
Yeah, we through our system, we're identifying like cohorts. So who else has a problem with the diabetes and heart issues that has similar symptoms as yours? And we can build this sort of Good Samaritan sense around there, that if you successfully handled it at some point, well, help someone else handle it. And I think those communities will grow, and it's critical. It's a huge part of that human touch.
One last question, everybody.
Or not.
Thank you. I just want all the Health Innovators teams to come up front, please. Well, this is one of our startup we are working on. We'll give you a speech if we succeed. Right now, we're trying to find out a good business model. What we're trying to do is we're trying to bring international patients from China and India to get admitted into American hospitals. So this system is a combination of tap and American Well. So people can ask questions and have a conversation with the doctors via audio, video, and chat. I also want to talk to you about our new initiative. And we're starting a co-working space 2 blocks from here, and we would love to work with other entrepreneurs, because what I've learned in entrepreneurship is right across that building in the Cambridge Innovation Center. That's where I've learned about entrepreneurship. I had no prior MBA or anything like that. I just talked to other entrepreneurs and just learned it from them, and that's the best way to learn it. And finally, I want to thank all my team members who have done an excellent job in hosting this event. We all thank you, and hopefully we'll get you again. Just write us if you need our help. We know a lot of people. We can get you resources. We are entrepreneurs, and we know how hard it is to be an entrepreneur, especially in the healthcare space. Because if you're a new entrepreneur, no one wants to talk to you. With that being said, thank you so much, and hopefully, please give a big round of applause to my team. Have a good night, everybody.